So, hypertensive disorders in pregnancy increase the risk of subsequent ischemic cardiovascular disease events. This is something which I'm sure the audience will have a fair idea of already. But just to provide you with an overview of what I will be talking about. Um, so, if there is just a way to minimize myself so that I can see all of the text, bear with me. So, what do we mean by hypertensive disorders in pregnancy? What impact do they have on women? Can I just check that everyone can see all of the text on the slide, that it's not being overlaid? Yes, my. Okay, fantastic. So, what impact do they have for women's cardiovascular health? And can they all just be explained by the mechanism of hypertension causing end organ damage? And then finally, what can be done to reduce the risk? So, the definition and impact of hypertensive disorders of pregnancy. uh, The definition, there are various conditions that are included in HDP, either pre-existing hypertension going into pregnancy, gestational hypertension that develops during pregnancy, or preeclampsia, with the latter being defined as new onset hypertension associated with end organ damage after the 20th week of pregnancy. Together, these hypertensive disorders affect nearly 10% of pregnancies and, importantly, account for about 14% of maternal deaths worldwide. And they are the second leading cause of maternal mortality worldwide, and a major cause of neonatal and maternal morbidity, the highest cause of maternal mortality worldwide being hemorrhage. Their impact on cardiovascular disease, I've decided to group it according to the subtype of hypertensive disorder. So if we start with gestational hypertension, women with that have a 2 to 4 fold increased risk of developing hypertension in later life, but they do also have at least a 1.5 times higher risk of having a major adverse cardiovascular event and a possibly increased risk of stroke. Women with chronic hypertension, unsurprisingly, will have an increased risk of stroke, cardiovascular events, atherosclerosis, and peripheral vascular disease. But that we know, in any case, that hypertension is a risk factor for all of those conditions. Women with preeclampsia, as well as having an increased risk of developing hypertension later in life, they do have a risk of stroke, which is 2 to 3 fold higher, and up to a 3-fold higher risk of a major adverse cardiovascular event, and increased mortality by 2-fold, which is not insignificant. The risk seems to be highest in women who develop preeclampsia before 37 weeks gestation, and those women in particular have an approximately 8-fold increased risk of ischemic heart disease. So the degree of increased cardiovascular risk does correlate with the severity of the hypertension, with mild hypertension being associated with a 2-fold increased risk, whereas on the other end of the spectrum, severe hypertension is associated with a greater than 5-fold increased risk. It's not known whether preeclampsia itself is the cause of the increased risk or whether it's actually caused by an underlying disorder. This particular meta-analysis and systematic review is well worth pointing out. This is, I believe, the 6th meta-analysis on this subject in terms of the impact of hypertensive disorders of pregnancy on cardiovascular risk. It's the 6th one, it's the most recent one, and it is the biggest one as well, which is why I've chosen to focus on it for a few moments in this talk. So the authors looked at 73 studies involving more than 13 million women, so a huge number. The majority of these studies were cohort studies, with just 7 being case control. And they were published over a quarter of a century, literally a 25-year period between 1995 and 2019. But the majority were published in the more recent decade of that time period. Majority were conducted in Europe, and then 20% in North America, 14% in Asia, just to highlight that. And the follow-up period ranged up to 4 decades out, depending on the study. Importantly, 26% of the studies did not adjust for any confounder when they were estimating the risk of cardiovascular disease, but the remaining studies did attempt to match for age, smoking, and other potential confounders. So the long-term relative risks, if we just look at the breakdown according to the type of cardiovascular disease from this very large meta-analysis. So 1.8 for cardiovascular disease, similar 1.8 for mortality related to cardiovascular disease, 1.7 for coronary artery disease, nearly 3 for heart failure, just above 3 for hypertension, and 1.6 for peripheral vascular disease. And an interesting point, the risk estimate of cardiovascular disease-related mortality was higher in studies conducted in Asia than in those conducted in Europe. And this just shows that increased relative risk of cardiovascular mortality in a scatter plot format. Really, that's quite striking. And the confidence intervals you can see for all of those studies, apart from 3 of them, the confidence interval is quite convincingly towards a higher relative risk. But the limitations of data, whether it's from this meta-analysis or from other studies, is how is something like coronary artery disease defined? Is it on the basis of a minor troponin rise, which was due to something else? Is it on the basis of non-specific T-wave changes that then resolved? Is it on the basis of plaque, which was found on a CT coronary angiogram, which is non-flow limiting? It's very difficult to establish how that is defined in any of these studies. There are significant unmeasured confounding factors that can contribute to the association or apparent association between hypertensive disorders of pregnancy and cardiovascular disease. Only a few studies adequately controlled all the cardiac risk factors, including, BMI and hypercholesterolemia and family history of coronary disease. The duration of follow-up as well in several of the studies was just not long enough to capture all cardiovascular events. And of course, this meta-analysis was conducted over a quarter of a century, during which time various advances would have developed in treatments or heart failure, coronary artery disease, valvular disease, etc. Can this increased risk be explained just by hypertension alone? I'm afraid it can't. Studies show that only up to 2/3 of women with cardiovascular disease after hypertensive disorders of pregnancy have persisting hypertension. So this phenomenon cannot all just be explained by hypertension. And there's this concept now of accelerated cardiovascular aging, where there's actually a greater prevalence of atherosclerosis in women in their middle age, 45 to 55 years, with prior history of preeclampsia, for example. There are differences in arterial stiffness in these women compared to hypertensive women during pregnancy, and these differences persist beyond a decade after they've had their child. There's an increased risk of premature valvular disease in the form of aortic stenosis, mitral regurgitation. So there is this concept of accelerated cardiovascular aging. And this really just illustrates that from a JACC paper, where it's not just the coronaries that are affected in these women, but the pump as well, the diastolic and systolic function of the left ventricle, the valves, aortic stenosis, mitral regurgitation. In red, you can see the HDP women, and in blue, the non-HDP women. Heart failure risk persists for at least a decade postpartum. There's a strong association between preeclampsia, eclampsia, and heart failure, both with preserved ejection fraction and reduced ejection fraction, even after other heart failure risk factors have been adjusted for, including chronic hypertension and diabetes. Women with preeclampsia, eclampsia previously remain at risk for long-term heart failure, even after the physiological changes of pregnancy have long resolved. This risk persists for a decade plus, as I'll show you in a graph. Chronic hypertension and diabetes have been identified as independent risk factors for heart failure with preserved ejection fraction, and they're found to be more common among women developing this than those developing heart failure with reduced ejection fraction. And here is a graphical representation from this JACC paper of the risk of heart failure hospitalization in women who've previously had preeclampsia and eclampsia. If I can please just draw your attention to the graphs on the right side, which actually show the years since delivery, and it's going out to 10 years, they continue to have an increased risk of heart failure, both preserved ejection fraction and reduced ejection fraction.
Dr. Sitara, could I ask you to conclude, please? Thank you.
Yeah, it's my last two slides now. So what can we do to help reduce risk? Plenty. The Federation, International Federation of Gynecology and Obstetrics, say that women should be screened where appropriate. They should have their blood pressure taken. They should be given prophylaxis with low-dose aspirin. If they're high risk, it should be started before 16 weeks of gestation. It should be advised on healthy diet and also on physical activity. All of these things can reduce the risk of hypertensive disorders of pregnancy. This reiterates that message from the American journal JACC. So the summary is that hypertensive disorders of pregnancy can present in 10% of all pregnancy and are the second leading cause of maternal mortality globally. They are associated with a twofold increased risk of cardiovascular mortality. And in addition to causing traditional vascular diseases, they also increase the risk of heart failure and valvular disease and atrial fibrillation. And the increased risk of future heart failure does persist for at least a decade, but there are things we can do to help as physicians, including screening, dietary and lifestyle modifications, and low-dose aspirin. Thank you.